next speaker is my real pleasure to introduce my friend Dominique DeZiegler. He and I had adjacent laboratories when I first came to the United States, so that's how long we have known each other. And we're still here, Dominique.
Yeah, the two of us.
Dominique will be talking about ovarian function and obstetrical outcomes, a window of endometrial vulnerability.
Thank you, Norbert. When you mentioned people who were there early on, at least there were two of us in the room. I want to thank the organizer. I want to thank Zev and Milton for inviting me. This meeting is fantastic, extremely well focused, and it's really a pleasure to be here. I have to announce that I have no conflict of interest pertinent to this talk. I received no travel funding. I just walked over. And this is a pleasure. My talk is a window of endometrial vulnerability. This is a talk into the unexpected. Let me give you an example. Sorry. Smoking kills. It may still kill this one, but it will not be premature. Our way of assessing the risk does not always fit with what happens. This is unexpected for this woman to deny the risk of smoking. And what we're going to talk about, the window of endometrial vulnerability, was really unexpected in terms of the known risk of IVF. We're going to talk about the fact that it's been said several times today, ART and ovarian stimulation are linked together from nearly the onset. We're going to talk about the obstetrical outcome linked to ART. We're going to talk about fresh and frozen, the risk of COS itself, if there is any, the impact of COS on obstetrical outcome, and finally, this concept of endometrial vulnerability. First IVF, natural cycle. Soon after, ovarian stimulation, to the point that now we are confusing sometimes the two issues together, confusing the outcome of ovarian stimulation with that of reproduction itself. It has been wed by necessity and still is necessary for IVF, as reminded to us earlier this morning. Now, the risk of undergoing IVF with ovarian stimulation, and I'm talking about a regular ovarian stimulation. There is the retrieval, there is the IVF itself, and there's a putback. The ovarian stimulation could carry all kinds of risk. We are rescuing follicles from atresia, and we are transforming them into babies. But it turns out to be safe. It could have been dangerous, it is not. The risk of ovarian hyperstimulation is something of the past, as Norbert said. The risk of ICSI versus IVF could have been dramatic, but it is not. There is no risk inherent to ICSI, and the risk of freezing, too, could have been high, but it is not there. So the obstetrical outcome, in terms of IVF, the babies are a little too small, a little too early. This is an issue that requires to compare the impact of infertility per se together with that of IVF. And here you have sort out this issue by assessing the risk of premature birth, ART outcome, less than 37 and less than 39 in women undergoing IVF for either a female indication or a male indication, presumably with normal women. And you see that the risk is higher In case of female infertility, 1.69, but it's still elevated with a value not including 1 in case of male infertility. So therefore, there appears to be a risk of premature birth, small for gestational age, in case of ART that supersedes whatever is due to infertility per se. This is a review of the issue that recently came out, and you see here the effects of infertility. This is the assessment of the obstetrical outcome in relation with whether it took more than a year or less than a year to conceive. And you see that it is better in terms of obstetrical outcome to not be infertile. This is ART per se versus infertility, and in this case, it favors IVF versus infertile or relatively infertile conceiving in more than a year. It favors the relative infertility versus IVF. So as before, IVF adds to the issue of fertility. This is the ART children versus the natural conception siblings. And these two, so therefore in the same people, and this favors the natural conception siblings. COS-IUI, 2 increases the risk in relation with, therefore, the ovarian stimulation rather than the ART per se. And frozen versus fresh, and this is the first step into the next part of the discussion. It favors unexpectedly favors, in terms of obstetrical outcome, the frozen. Fresh versus frozen embryo transfer, this is the unexpected. No one would have dared to imagine that it is safer, probably safer, more natural to proceed through a freeze and thaw embryo rather than a fresh transfer. But there are now numerous publications alluding to this. This is a meta-analysis that shows that favors frozen for preterm labor. This is small for gestational age, favors frozen as well. This is low birth weight, favors frozen. The risk of cesarean section, however, is unaffected. I will not tackle the issue of the large for gestational age, which has been reported in frozen embryo transfers. It's puzzling, and it is beyond the discussion that we're having today. This is the Nordic data. It offers the advantage of comparing not just frozen versus fresh, but relating this to natural conception. And you have here the data. Preterm labor, you have the spontaneous conception, the fresh and the frozen. And you see that the frozen is nearly at the same level as the natural conception, whereas the fresh is increased. So therefore, this speaks for an effect of IVF that is getting to be focused on an endometrial effect, because whatever consequences of IVF may have, it appears to affect primarily the fresh transfers. COS and oocyte quality. This was discussed earlier this morning, and I just add a couple of arguments to the discussion to actually convince you that COS might have increased the risk, but actually it does not. Let me give you this piece of information. This, you will agree, is in a large number of cases from a UK registry, and this is what they actually did. They looked at assessing the quality of embryos based on first trimester abortions. taking into account that this is the ultimate marker of oocyte quality. Now, you have age groups, if you focus this part of the diagram. As expected, the risk of early miscarriage increases with age. But within age groups, you have several subgroups that are linked to the number of oocytes retrieved. So there is no increase, further increase in miscarriages linked to a large retrieval of oocytes, more than 15 for this group, and possibly even a trend for less. So the fact that COS does not increase, does not alter oocyte quality appears to be convincingly demonstrated here based on first trimester abortions. COS and obstetrical outcome. So we're now dealing with this issue that the risk of IVF appears to not be related to the stimulation itself. It was said earlier this morning that there's no increased risk of aneuploidy linked to ovarian stimulation compared to natural cycle, that the quality of oocytes, they could have been worse with stimulation. There could have been all kinds of reasons that they might have been, but turn out to not be the case. The adverse outcome of IVF appears therefore to be linked to the ovarian stimulation itself and probably to an effect on the endometrium. So this is again a large number study based on the START data conducted by Valerie Baker at Stanford. And this is what they looked at. It's a little complex, but let me take you through this slide. First of all, you have the risk of the length of gestation and the birth weight in relation with the number of oocytes retrieved. And this is only in fresh transfers. All the START data are for fresh transfers in general, and particularly this one. Now, the trend, as you see, is highly significant for a decreased length of gestation and decreased weight of birth in relation with the number of oocytes retrieved. An impact of the ovarian stimulation on the outcome not linked to the oocyte quality. Not linked to the oocyte quality because the same analysis conducted in donor egg is negative. There is no trend. This is, by the way, the day 2 or 3 transfer, and this is the blast transfers. And the trend is for both transfers in the fresh transfers, but in donor egg, there's no such trend for either transfer. So therefore, this consequence, which appears to be related to the importance of the response to COS, is only in the fresh transfer, not in donor egg, and appears therefore to be exerted at the endometrial level. Now, there are issues as to whether there are differences between blast and day 3 transfers, and there might be, but for sake of time, I will skip that. The cryopreservation, vitrification versus slow freezing could have increased the risk, but this is not the case. If you look at this data, there is an improvement of the outcome of the freezing technique, okay? But there is no increase in malformation or miscarriage rate. And now we come to the point of the talk, which is the window of endometrial vulnerability. You've heard yesterday afternoon talking about endometrial receptivity. And we heard about the window of endometrial receptivity, which is defined. Some people say it may move forward, backward, but in general is within the first few days of exposure to progesterone. This has been defined, historically speaking. I mean, Norbert and I can remember with the first days of donor egg, whereby the transfers were performed at different times, And the window of endometrial receptivity was defined really from those days. What I'm going to talk to you about is the window of endometrial vulnerability, the changes that we have seen, the changes that IVF conducts, and the risk of IVF in terms of obstetrical outcome appears to be expressed by an effect on the endometrium which clearly lasts longer than the window of receptivity and clearly includes the estrogen effect, and the duration of it is unknown. Concept of placentation. This is a study conducted in mice. Blastocysts were obtained from a mouse and transferred to two categories of mice, which were either in the natural cycle of the mouse, in the estrus cycle, or in stimulated mice, the recipient. And you see the difference in terms of the area of placentation. It is markedly thinner in the superovulated recipient, and this translates actually into the problems that we see in IVF. Smaller pups in the superovulated cycles, and small and lighter and smaller placenta. Now, these issues of endometrial vulnerability, which have consequences on obstetrical outcome, are likely to be, when confirmed, if confirmed and when confirmed, likely to be the arguments for reverting to the freeze-all technique or not that far exceeds a single-digit increase or decrease on the pregnancy rate. And it appears to be that this vulnerability of the endometrium may not be the same in everybody. It may not be the same in every ethnical groups. There have been reports that IVF data are poorer in black women, and these data were generally ignored due to the fact that people said, well, this is due to the fibroids. Yes, but there have been since data from Northern California indicating that the outcome is poorer in Asian women as well. And this was published by several groups, including Victor Fujimoto. But this appears to only affect the fresh transfers. This is data that we reported. This is data from a group. One of our former fellows came from Cambodia and went back to Cambodia and actually started an IVF program, and this is what we got. They started the IVF program, and after 4 months of operation, she called me and said, well, the pregnancy rates are good, but not so good. However, the frozen is better. This program started in the fall of 2014, and this was in March 2015. I said it's impossible that you flunk the fresh if the frozen works. Now, in spite of what I said, she decided to stop in March 15th all fresh transfers. And these are the results of all frozen transfer from until ESHRE, from March 15th until ESHRE. First transfers after the retrieval, and these are the results. For the fresh, until then, 33%. From the time she changed, it was 70% onset and 66% clinical pregnancy rates. So, whatever is affecting IVF affects people differently according to the ethnic groups. Asian people appears to be most vulnerable. Since then, Valerie Baker had data going in the same direction. And some subgroups of people are particularly vulnerable to the effect of ovarian stimulation on the endometrium, the endometrial vulnerability. In case of Asian women, it is probably linked to a difference in estrogen metabolism. This is data indicating that estradiol levels in women, in Asian women wearing a patch and whose ovaries were suppressed is way higher than it is in Caucasian women. So time to conclude, and I hope I stayed within my time frame. You heard yesterday the fascinating window of endometrial receptivity. I brought you today to the concept of the window of endometrial vulnerability. This is an emerging issue. No one would have believed that the danger might come, the danger in IVF, consequences in terms of obstetrical outcome, might come from the endometrium. When so many other things were frightful, ovarian stimulation, rescuing follicles from the trash can, so to speak, from atresia, manipulating the embryos, then freezing them in the fumes of liquid nitrogens. All of this turned out to be safe. And the weak point of the chain appears to be where it was not expected, at the endometrial level. So it is for us now to see in the future what are the ways to actually avoid those consequences. It is possibly time to relook at the ovarian support, particularly in the frozen embryo transfers. I know there is a talk this afternoon on luteal phase support. We gave ton loads of progesterone because we think that more is better. Is it true? Do we really know that? It is time that we look. We now have identified a moot point, a soft point that we have to look at into more details. And with this, I will thank you very much.
Thanks, Dominique, for an excellent, very interesting talk. Are there any questions?
I just have a remark. It's interesting, in the last ASRM meeting just a few weeks ago, I think it was a prize paper from Vietnam, the largest RCT on freeze-all versus segmentation of the cycle. And it was fairly large, and there were a few hundred patients in each arm, and there was no difference in the live birth rate. Is it the same group?
No. Vietnam and Cambodia.
Oh, sorry.
It is, however, I talk to these people. I think they're probably using, all right, so we do things and we have different results. This is why we have to have meetings and talk about it. I think they're using mild stimulations. That's my explanation for, I talk to these people, they're using mild stimulations and probably avoid the problem that way, or the freezing is maybe not up to snuff.
Dominique, do you have any data on age, how age in all of this plays?
No, it's a very good point. It's a very good point. We don't know. When all of us had access to the freeze-all technique, we wondered who were the candidates. We could do it for everybody. But we have here the lab director from Cochin, and he would have killed me more often than he wanted if we had decided that, because he would have got bankrupt. So we have to select the cases. At first, we might have thought that the poor responders would be the right candidate. But looking at the impact of the stimulation, it may not be the case, but we don't know. In the US, there are several groups that do freeze-all for everybody. I think the final response to that is what you said yourself, individualized. But we have to figure out exactly who are the best candidates. Milton? Catch the ball.
I have data both in age about Asians. Generally speaking, it's true that for Asian, the pregnancy rate with freezing FET is much higher than fresh. I cannot explain it. I don't think anyone can really explain it. We have to do, I think that the data that was done by Fujimoto has been years ago. And I think in the future, maybe, when we get the transcriptor and things like that, metabolics, maybe we can do a little bit more. But I cannot explain why, but it's true. This happens throughout ages. No matter whether you're young or in middle age or old age, over 40, the pregnancy rate with frozen is the same. In our center, we have ongoing pregnancy rate of 35%, but live birth rate of 35%, but the fresh transfer is only about 45% pregnancy rate. But frozen transfer, both in young and old, is 67%. It's the same. So frozen embryo transfer is definitely the way to go. I really cannot explain all the details because I don't think anyone in this hall can explain it. But that is the truth. Of course, Robert is another one with freeze-all experience.
I may add a comment to what Milton said. The data from Victor Fujimoto is all Asian women in Northern California, which includes Korea, Japan, China, and Southeast Asia. Now, you're probably dealing mainly with Chinese people, and I think this is opening our eyes to the fact that we have to single out those differences by ethnic groups in more details than we have done so far. Yes?
Thank you very much. I think I only have 2 comments because I have the lecture in the afternoon, so I don't want to tell too much. But I think there are 2 things that we have to look at. The way of the triggering of the ovulation. There is a big difference in the whole hormonal and endometrial receptivity if we trigger with HCG or if we trigger with GnRH agonist, and also the way we treat the luteal phase. And that might also make the difference between pregnancy rates in the all segmented cycles and in the fresh cycles, looking on the difference what they used for triggering. In my center, we don't see any difference between frozen embryo transfer and fresh transfer concerning pregnancy rate. The second comment I wanted to make is when we look at the literature, and even yesterday by the presentation of Carlos Simon, the miscarriage rate in frozen embryo transfer is always higher than the fresh transfers. And
the what?
Always higher than the fresh transfer. So we had to look at the bottom line, what will be the live birth rate per started cycle. And that might also have a difference.
So we look forward for your talk, because the luteal phase support, I give my input into this. Luteal phase support has to be relooked at with those issues in mind.
Okay, thank you very much for a very interesting session.